Hello and welcome back to my YouTube channel. In today's video, I will be talking about chronic bronchitis. So let's get started. Chronic bronchitis is a type of COPD and is defined as productive cough for at least 3 months in each of 2 consecutive years. The etiology or risk factors are smoking, air pollution, occupational exposure, recurrent infections, and genetic predisposition. Talking about the pathogenesis, when there is exposure to the irritants, there is chronic inflammation which causes mucus gland hypertrophy, which leads to increased mucus production and decreased ciliary function, causing airway obstruction. Now, let's talk about pathological changes in chronic bronchitis. Well, grossly, the bronchial walls are thickened and there is excess mucus production. Microscopically, goblet cell hyperplasia is noted, chronic inflammation is noted, and bronchial fibrosis can be seen sometimes. There is increase in the Reed index more than zero point 0.4. So, what is Reed index? Reed index is actually a histological measurement and is used to assess mucus gland hypertrophy in the bronchial wall, a hallmark of chronic bronchitis. So, how it's calculated? Well, Reed index is equal to thickness of mucus glands divided by thickness of wall between epithelium and cartilage. It is measured in a cross section of a bronchus, not bronchiole, only applicable in large bronchi with cartilage. A patient with chronic bronchitis presents with productive cough, wheezing, dyspnea, cyanosis, that's why also known as blue bloater, frequent infections, and right sided heart failure. The complications of chronic bronchitis include pulmonary hypertension, cor pulmonale, pneumonia, exacerbations of acute infections, and respiratory failure. The investigations done for chronic bronchitis is chest X-ray, which shows increased markings, pulmonary function test, which shows decreased forced expiratory volume in first second, and decreased forced expiratory volume in first second divided by forced vital capacity. ABG shows hypoxemia and hypercapnia, and sputum is also examined for pathogens. So now let's talk about the management of chronic bronchitis. Well, the patient should quit smoking. Vaccinations are always useful. Rehabilitation is done in form of exercise, education, and helping to quit smoking. Pharmacological means of management are bronchodilators, corticosteroids, mucolytics, antibiotics, and oxygen therapy. For prevention, avoid smoking, reduce pollutants, early infection treatment, and workplace safety is required. Now, how to differentiate clinically chronic bronchitis versus emphysema? In chronic bronchitis patients, cough is present, whereas in emphysematous patient, dyspnea is the main symptom and cough is mild. In chronic bronchitis, sputum production is copious, however, it is scant in emphysema. Cyanosis is common in the patients of chronic bronchitis versus it's rare in emphysema patients. Breathlessness is mild in chronic bronchitis, as I have described earlier, and it is severe in cases of emphysema. The chronic bronchitis patients are also known as blue bloaters because they present with cyanosis and a bloated appearance, and the emphysema patients are presenting like pink puffers because their oxygen levels are almost normal and they puff while breathing. In this chart, I have again emphasized the differences between chronic bronchitis and emphysema. So, chronic bronchitis is a preventable and manageable disease. Smoking cessation is the key, and early diagnosis and therapy reduce the complications.